Good evening, everyone. So this is the Chapter 15 lecture on death and dying. It's something that we do have to kind of deal with in the operating room from time to time. We do have patients who expire in the operating room, and this is kind of how we kind of deal with it. And also, we'll also talk a little bit about like organ procurement, maybe some transplants, things like that. This all kind of ties into like death and dying, especially someone in the ICU is expiring like a patient. They may be an organ donor, and they'll come to the operating room to retrieve those organs, and we may be the tech in the room doing those procedures. So, um, like I said, death in the OR, it's rare, but we kind of have to understand, not only our procedures and what we have to do as far as like taking care of the patient, and uh, maybe even some of the things that we're not allowed to do if a patient, dies on the table or something like that, until the proper authorities have been able to come in and look at the body and things like that. So, but also we have to think about how that's going to affect the staff and the patient's family and things like that, having to deal with those kind of things, right? So, there's a lot of different ways that we can look at death. There's a social kind of perspective to it, our own personal perspectives, an ethical, legal, and like kind of a medical definition of death. But kind of the reason that we learn about this as techs too is that we can provide a little bit more kind of like compassionate kind of care to the patient and to their families, and understand kind of what they're going through. For me in my own personal life, I didn't really deal with death until I was 30. I had an uncle, like a favorite uncle when I was a kid, who had died, but I was still kind of a kid. But it wasn't until I was 30 that I really had to deal with it in my own personal life, and that gave me some more insight into some of these things these families would go through and things like that. So um, it just kind of gives you a priority check in life. So um, and so the definition again, end of life, we're talking, which way are we looking at it from? Are we looking at it from a personal view, an ethical view, that kind of thing? But what we try to do in the hospital is we just try to, give some support where we can, be there, be an ear to listen to, maybe a family member, uh, something like that, or maybe one of the, your fellow techs or a nurse or somebody who was in the room on a patient that died or anything like that. Was it a period where death may have been expected? Was the patient what we call in the medical field like circling the drain, where they already, like organs are failing and things like that? So, was it expected? Was it sudden? You know, but and then, death is usually within days of pronouncement. That doesn't make any sense to me. So, um, but it's the it can it we mark kind of the time of death when we stop doing anything to save that life anymore. We stop doing any kind of medical interventions and things like that. It's like, and you've seen it many, many times in all the medical shows and things like that, when they're doing CPR on somebody, and then somebody's like, okay, and they just stop and they're like, all right, time of death, and they look up at the clock and they call it. But or this is also like the time when they say, go ahead and pull the plug, things like that. They're still going to provide like a comfort care, not only for the patient but the patient's family, and usually a lot of people think that when you pull the plug, like the patient just immediately dies, and it's not really the case, because those machines that were pumping oxygen and all that is still in the system. So your system has to exhaust that first, and then the patient starts to go down. So sometimes people, when they pull the plug and they don't instantly see a flat line on the monitor, um, they start to think that the patient is maybe trying to hang on or something like that. But it just takes a little bit of time, and then uh, you start to see the monitors going down, and it's kind of a gradual. Um, Cause of death is usually determined by the CDC. The CDC does like their classification of all their diseases, and there's a code for each disease. There's a book about yay thick. It's called the ICD-10, the International Classification of Diseases, version number 10. They may be on to 11 or 12 by now. The reason I remember number 10 so well is there's an actual code in there for alligator attack, and that being a cause of death. There's a code for that. So it had to have happened enough times that they said, okay, we need to now have a code for this rather than some other like animal attack or something like that. They specifically classified it for an alligator attack. So um, and the cause of death can greatly influence how the community responds or even the family responds to that person's death. I mean, if you think somebody had a heart attack and died, and then you learn that that heart attack was brought on by the use of maybe like cocaine or something like that, and you didn't know that that person was in, or that that person was a high member of that community, like a mayor or something like that, and suddenly dies as a heart attack that was related to like a cocaine overdose or something like that, then you can see how that can differ and that can change kind of views of things and stuff like that. So um, this is the Kubler-Ross model of death and dying. Some of you may have heard of this before. These are the stages that you go through. Um, like if somebody gets an inoperable cancer diagnosis, like pancreatic cancer, something like that. Um, your first stage is you deny it. You're like, you kind of think, I don't have that, or this can't be happening to me. And then you move into anger, right? You start trying to push people away because you don't want them to have to suffer watching you die. You're just mad all the time because you feel like there's nothing you can do. And then you move into bargaining, where you start, well, what if I just do this? Will that give me this or that? Or and then once you start to realize that there's really nothing that you can do, you kind of fall into some depression, right? You get real sad and just sullen. You don't want to do anything. You don't want to go anywhere. You don't want to see anybody. You just want to die. You just want to curl up and go away. And then eventually you come to an acceptance of, okay, this is going to happen. And let me get some things in order. Let me talk to those people that I may have wronged, and talk to those people I love, and all that, and get all of that done and taken care of. Um, so denial, they say it's a defense mechanism, right? That you just got the news, and you just want to know, because it takes a while for it to kind of soak in, and for you to go through these stages and really come to an acceptance on it, right? Um, there's that anger, right? You're pushing people away. You're just mad at everyone. Somebody comes in, hey, how you doing? Why do you care? You never asked me how I was doing before, or anything, like like stuff like that. Or you know, family starts coming around a lot and everything. I don't hear from you for years, and now all of a sudden you're coming around because you're trying to get something from me. Things like that, trying to lessen the blow for people in one regard, and then the other regard you're just mad because you can't do anything. There's nothing you can do about what's going to happen, and you're just frustrated and angry. Um, and that this bargaining, they're trying to postpone their death. They're trying to give themselves more time. If I just promise to be good, take this away. Right? If I yeah, and this is the time that a lot of people will become very religious and spiritual, and seek out a higher power and try to bargain with that higher power, trying to give up something so that they may be able to go on for a little while longer. And then you fall into that depression because you're realizing that nothing that you can do is working, and they treat it like regular depression. Right? You may have to be put on medication for it to kind of keep from falling into that deep depression and then never really coming to the acceptance and dying as a result of the depression. And then finally you get into that acceptance, and it's usually when the patient and the family have all come together now, because the patient isn't the only one going through these stages. So are their loved ones. They're they're right with them in that denial. And some people skip certain stages, and sometimes you regress back. You get to a bargaining and you realize the bargaining's not working, and you get mad. So you go down one, and then you come back into trying to bargain again, and eventually you realize that that's not working, and then you move into your depression. And but this is kind of everybody coming together. Everybody knows that death is a part of life. We're all going to die one day. No one lives forever except for um, oh no, he didn't live forever. Bicentennial Man didn't even live forever. He changed himself and ended up dying. So no one, even no one. But we give this support and comfort, right, to uh, a dying patient in the OR. This Steve, we're talking about the ones that are coming in that are maybe like live organ harvests. And I know that sounded kind of crazy, but these are patients who, the very second that they get taken off of life support, if they don't start going down in that time frame, then we can't harvest their organs. So sometimes we bring them in, like we unplug it. As soon as they go down below a certain level, they get wheeled straight into the OR. There's other ones that, they kind of keep on life support, and then they'll let them expire in the ICU, and then we bring them over. But there's other ones where it's called a beating heart, uh, I believe beating heart organ harvest, organ procurement. Um, but you got to be able to, kind of, in order to provide this kind of support and comfort to patients and their family and stuff, you got to be a good listener. Your observational skills. You got to be able to pick up on, people's kind of emotions and things like that, and be able to, uh, articulate to them, you know, what's happened, and uh, what they can do next and things like that, and also realize that uh, they're not hearing really everything that you're saying sometimes, because they're focused on something else. They're focused on their loved one, or the actual surgery they're going into, if we're talking about the patient. And so, um, and you never want to talk about, like, that the patient's going to be cured from this surgery, or focusing on anything that's denial of death. You just basically you want to kind of stay away from a little bit of the, like, saying, like, talking about death and dying and things like that. You let the patient and their families bring that kind of stuff up, and then you just kind of talk to what they're saying. um, that family is very important for that patient, because if the family's kind of going crazy, then the patient feels that stress, and that's even worse on them and things. And they're already angry and frustrated, and now you throw in a little bit of grief and sadness and all these emotions, and you're going on this roller coaster. And they may need you know, a little bit of help with coping. You may be able to, if you've experienced, some death and dying in your own personal life and everything, you may be able to offer up some things that kind of helped you and say, you know what, and you can even think of it like, what really helped me was a nice, warm cup of coffee or something like that. And you can go and bring that to the patient's family and be like, I thought you guys might, need, some of this, something to just kind of hang on to, something that's warm and, comforting. Yeah, it can be just something as simple as that, or it could be, a little bit more, and it may even turn out that, you become kind of uh, lifelong friends with this one patient's family because you happen to be there for them in a grief time and things like that. So, uh, and another thing to think about is that when someone dies, not only do they leave like whatever money they had behind to be, doled out in their will or whatever, right? But they also leave behind their debt. And that debt usually gets passed on to the next of kin because it all still has to be paid for. I know that's a crazy, crazy thought, but you would think that when somebody died, then so did their debt. That debt just gets passed on to their spouse or whoever's going to be the like executor of their estate, basically. They pick up all of their debt and assets. So, um, and that may be saying, and the hospital has resources and numbers and stuff to like support groups and help groups and everything for financial reasons and for emotional support and everything like that. So we can, offer up maybe some of that too as a, something that they could seek out and find and uh, help, help them cope outside of the hospital and things like that. Um, Now, if you have a sudden expected death, um, so this is something that I personally experienced uh, when I was working in San Marcos, Texas, which is just north of San Antonio. It's about halfway between San Antonio and Austin on the I-35 corridor. Uh, my mother lived in Killeen, Texas, which is up near Waco, and my brother lived in San Antonio, and I lived in San Marcos. It was a Sunday, August 12th, 2007. Uh, my mother in the morning had gone down to visit my brother in San Antonio and him and his kids and stuff. And uh, on her way back to going to Killeen, she was going to stop by my house and visit with us and then, go back up to Killeen in the evening. And at about, it was about 11 o'clock in the morning, I was on call and I had gotten called in and I was driving into work and I called her to let her know I was getting called in. But that she was more than welcome to still come by the house and hang out with my wife and the kids. Uh, but I didn't know how long I was going to be at work. And she said, uh, okay, that's no problem. We can visit another day. I'll just head back up to Killeen when I'm done down here. And I was like, okay. Well, it turned out that it was a super, super busy call day. And we were doing cases all day and into the night. It was just one after another. I remember there being a C-section and the baby being born at 2:42 p.m. I remember that being looking up at the clock and calling out time of birth. And then at about 9 p.m., one of the other techs who worked there came walking in. And I asked her why she was there. And she said she didn't know that your wife just called me and asked me if I could come up here and take over for you. that she needed you to come home. And I was confused, and I'm like, okay. So I call her, and she says she doesn't want to tell me over the phone, that she just wants me to get home. I'm like, okay. At the time, my brother was not what you would call uh, friendly with the law and law enforcement. I actually had a warrant out for his arrest. Uh, so when the my first thought was that something happened to my brother, and but my wife wouldn't tell me. So I called my sister-in-law, and she said that nothing had happened to my brother, but that I just needed to get home. And I was like, okay, like nobody would tell me anything. So I drive home. My wife tells me that my sister called and was wondering if we had heard from our mom. And uh, I was like, no. And I told her what had happened, and she's like, I know. She had called me, and she should have been home by now, but she's not answering her phone. I can't get a hold of Charles, our stepdad, and uh, nobody's at the house. And she said she tried calling the highway patrol to find out the information, and they told her that they couldn't release any information to her because my mom and my sister had different last names. They couldn't give her any information over the phone. And my brother couldn't call. The police had actually gone to my brother's house and knocked on his door, and he thought they were there for him, so he hid and didn't talk to him. And nobody answered the door. So I call, and I remember it was Officer Garcia got on the phone and told me that at 2:42 p.m. that afternoon, my mother was involved in a head-on collision on Highway 281 and was pronounced dead at the scene. Um, I mean, it was almost 14 years ago now, and it's still uh, not uh, the easiest thing to talk about. It's gotten easier over the years, but it takes a great toll on you. And this is what we kind of empathize with our patients and our patients' families uh, who have to experience something like this. Um, you know, it took a little while to get over it, but you know, you get through it. It's not, you realize it's not kind of the end of the world. You kind of go through those same stages, that denial, um, you know, anger, bargaining, depression, and finally coming to an acceptance. So the patient's families do go through that same uh, Kubler-Ross model of acceptance. Um, on the ethical side, right, some things to think about. You know, it's each of us his own individual right how we live or die. Right? It's our right to die. It's our right to refuse treatment, and at any time we can be started with treatment. We can be halfway or almost done with treatment and just stop because that's what we choose. It's it's our body, it's ourselves, right? It, uh, uh, some paperwork that may be involved are things like advance directives and living wills. An advance directive is a set of rules or a set of things that you want done to you uh, while you're in the hospital, right? It's your medical kind of decisions that you get to make for yourself and you get to write down, and they have to follow even if you become like kind of incapacitated and they can't ask you. A living will, um, it talks more about uh, how you want your care done, uh, even while you're still conscious, right? You're a dying patient. This is what I want. I don't want these kind of pain meds or whatever. And then um, you also assign a power of attorney that can act on your behalf. And there's different kinds of power of attorneys. There's medical, there's financial, there's um, absolute. You give somebody absolute power of attorney, they have complete say over any decision you make and what you do with your money, all of that. So careful who you give power of attorney to. Power of attorney to. These do not resuscitate orders or DNR orders. It means that if a patient is coding heart attack or respiratory failure or something like that, you are not to do anything to bring them back. However, a DNR order does not apply in the operating room because the patient has signed that informed consent. The informed consent trumps the DNR because they have been made aware of the situation. They know the risks and the benefits of the surgery, and they signed off to do the surgery. We're doing something um, that is supposed to advance life, with surgery. We're trying to prolong, and it's implied that if you were to code in surgery, that we still bring you back. The only thing that will trump the consent is what's called a DNAR. See, a DNR is don't resuscitate me, so don't bring me back. A DNAR is a do not attempt resuscitation, so we can't even touch them. We're not even allowed to try to bring them back. Palliative care, it can make the dying process a little less painful, right? It's not going to provide a cure. This can be, the like pain medications and things like that, the hospice. You just like a comfort kind of care, right? Falls under the ethical because, should we kind of coddle those who are dying or just, take them out? I know that I think we should coddle, obviously, but that's is that a drain on economic resources and social things and those monies that could go to something else, to the hungry or whatever. Um, and then your organ donation. Who makes the decision for organ donation? The patient does. Right? If you check that box on your driver's license form, on your driver's license, it says that you are an organ donor. So you made that choice. Right? The only other person that can make that choice for another person is if they're the power of attorney over that person. And they say, yes, I want the organs donated. Cultural competence, right? We've talked about this. This is you being aware of other people's cultures and treating them with some kind of respect, right? And acceptance, right? It may not be the way that you do things, but so what, right? It's the way that they do things. So we kind of, in the healthcare field, we kind of try to curtail how we give our services to our patients based on, how they want it given to them. Some examples would be in certain cultures, uh, a male does not speak directly to a female, especially if she's married. You need to speak to her husband, and then he will talk to her. Others don't like direct eye contact. They see it as a sign of rudeness. Right? You shouldn't. Don't be looking me in my eyes like that. Like so. And becoming culturally competent is you learn about the other cultures. It takes experience, right? You get around people who are of different culture and things, and learn about their food and their traditions, and you know what they like, what they don't like, what are absolute no's, what are alacious yeses, things like that. That we learn about each other, and we kind of accept that. You know, oh, you eat you eat that. I wouldn't. Uh, to me that doesn't seem appetizing, but hey, if you like it, you like it. That's cool. All right, that's your favorite, whatever. Um, and in certain cultures, death may not be seen as like an ending. It may be seen as like just a new beginning into something else, and you don't see them going through those same kind of the Kubler Ross model stages of acceptance. Right, they've already that's already part of their culture. Death is just part of their culture, or something like that. And there may be, you know, if the family wants to view the body, there may be something culturally that we have to, maybe take into account. Um, but whatever the preparations of the body, obviously we have to have still that patient's dignity in mind. Right? We're still covering up the areas that need to be covered, that kind of thing. We're making sure that no one's like, defacing anything, or you know, messing around with the body when they're viewing and stuff like that. Well, you'd be surprised. People are people sometimes. Um, so the actual determination of death comes with assessing the patient. You're feeling for a pulse. You're watching the EKG monitor. You're looking for breathing, checking pulse oxes. You're looking at body temperature. You're checking vital signs. And if all of them, if at least three of them out of the four, blood pressure too, right? If you're getting low readings on everything, the patient's unresponsive, then we're looking at getting close to determine, saying that the patient has expired or is dead. Right? There's legal implications with that. Right? On page 309 in your Fuller textbook, box 15-1 has got all the criteria that a patient has to meet to say, okay, they're dead. Right? So that's that legal kind of implication. Because if not all those boxes are checked, or not enough of those boxes are checked, and that patient turns out they weren't dead, or they weren't dead at that time, and because you didn't do anything further to help them, they ended up dying, then the medical professional could be held liable. Um, and then post-mortem care, this is preparing that body for viewing, right? And like the mortuaries, this is where they're doing like the embalming fluid and things like that. That's replacing all the fluids in the body with formaldehyde to preserve the tissues. And then doing the makeup and dressing them and things like that to make them look like, putting them in like their favorite suit and stuff like that. Uh, just getting them ready so that the family can view. These are some of the changes that are going to happen in the body when you uh, die. And you're going to temperatures going down, so the actual skin and everything, the body will feel cold, and you'll definitely feel it. You won't expect it to be as cold as it is. Loss of muscle tone, so everything will just kind of look droopy and kind of flabby and things like that. The eyes will be open, I don't know, it seems a little weird, right? When you think when you're sleeping, your eyes are closed, but the eyes will open, right? The jaw drops open, and then you get what's called liver mortis, and then everyone's probably heard of rigor mortis. Right? Liver mortis starts within 20 minutes or so after death, and the areas around your ears and your cheeks are going to turn like kind of purple and red because your liver holds a lot of like metabolized broken down blood and stuff like that. There's a lot of blood in the liver. So then when you die, that doesn't have anywhere to go. So it just starts to kind of pool in places. And that's why you get that purple. It almost looks like you're bruised in those spots. Um, and then the rigor mortis, this is that stiffening, right? It peaks at around 8 to 10 hours after death is when you've got the full rigidity, right? And your eyelids, that's why the eyes open because all those muscles go rigid. So then the eyes will open, which is also why you see in like some of the old Western movies and maybe some other movies and stuff, somebody dies and then they'll put their hands, they'll close their eyes for them. If you do that in real life, as soon as you let go, they'll open back up. So that's why you've also seen them put coins on the eyes. Uh, the coins actually represent the money that you are to pay the ferrymen at the river Styx. That's to take you to the next plane, I guess, of existence, the river Styx. That's why they used to put 2 quarters, because it cost 50 cents. Some of the procedures we do for postmortem after a patient dies, we want to elevate the head of the bed, right? That keeps that blood from pooling in the neck and the head. It keeps the gravity keeps it down. We'll close the eyes, keep them closed. We'll close the jaw. We'll put absorbent pads around and underneath the patient because you're going to start to leak fluids and things like that. Um, any like drain, catheter, IV, ET tube, any of that stuff that was in the patient gets left right where it is until the coroner comes and gets to view the patient and do his assessment or his or her assessment. Right. Any visible wounds, like if we had a open, we were doing surgery, X-lap, or we were working on an arm or whatever like that. We would dress those. We would put dressings on them and actually do the wrap and stuff like that. Anything that's like embedded into them, whether it be the ET tube or something like that, or we may wrap something around that to just kind of protect it to hold it in place. We will clean the body off only when it's not, the coroner doesn't have to come and see the patient. So this would be something we do after we've talked, because there's a whole set of, there's like a death book at the front desk of every OR department, just in case this happens. And it walks you through everything you're supposed to do step by step. And one of those steps is calling the coroner's office, and then they'll make a determination on whether they actually need to come out or not and view the body and do like their thing. If not, if they're not coming, then we can clean the body up and everything like that. If they are, then we have to wait for them to view it and let us know that everything's all clear, and then we can go in and do it. And then there's a bunch of documentation and paperwork that goes with it as far as filling out, causes of death and, um, everything that happened leading up to and all this stuff that then gets, put into the record and onto the death certificate and things like that. So, um, the it's usually the surgeon who's filling out the most of that documentation, and the anesthesiologist. They're kind of doing it together, because they're the ones who are going to be seen kind of as in charge there. If it is a coroner's case, if it's a death in the OR, it's a coroner's case. But we call them, and then they can tell us over the phone whether or not they're going to come out or not. If there was an unwitnessed death, so the patient was up on the floor, um, alone in their room, and they just expired, and nobody was around to see it, then they then the coroner needs to come and investigate to see, just to make sure that it was like a natural causes kind of thing or whatever. If the patient dies after being transferred to another hospital, then the coroner has to come and investigate as to what happened during that. Was there something that happened during that transfer? Was something not followed? Whatever. If there was any kind of criminal activity that may be suspected, if maybe there was a nurse in Reno who was going around and injecting people with succinylcholine. For those who don't know, succinylcholine is a muscle paralytic. And if you remember from your anatomy and physiology class and respiratory, your diaphragm is a muscle for breathing. And if you paralyze that muscle, you are not breathing. So, but the other thing about succinylcholine is, yes, it does paralyze all your muscles, but it does not put you to sleep. So you suffocate wide awake. If there was a suicide, patient killed themselves, right? If a prisoner dies, uh, if the patient had some kind of infectious disease, but that wasn't the primary reason they came in, the coroner needs to come and check that out and make sure what kind of disease it was, and it's not like transmittable and that kind of thing. And then if somebody dies in the workplace, one of the staff members. I also saw this in Reno. An ST I worked with, he had been in a car accident, had gotten addicted to painkillers. A few months after being back at work, he was on call one weekend evening. He went in. They finished the case around 1 a.m. or so. His wife called up there at about 3 a.m., wondering where he was and if he was still working. And they told him no, that they had finished a couple hours ago. So they went around that apartment looking for him to see if he was still there. And they found in one of the bathrooms, it was locked. They got security to come and get into it, and they found him on the floor, dead. He had dug into the anesthesia sharps box and pulled out what he thought was fentanyl, because there was a anesthesiologist who would he would change the labels when he threw away his syringes, his unused medications. And he would take the fentanyl sticker off what was actually fentanyl and put that fentanyl sticker onto what he didn't use of his succinylcholine and put that in the sharps box. So when somebody went in there and pulled out what they thought was fentanyl, which is a nice kind of happy drug, painkiller, and injected themselves with that, they really just paralyzed all their muscles. So, organ recovery, right, or otherwise known as organ procurement, right? Permission is made in advance, right? You can't die and then say, okay, now you can take my organs. You got to tell them while you're still alive, right? There's tissue and procurement, organ procurement agencies all across the country. There's usually ones that handle, all like the different regions. The patients have to meet certain medical criteria in order to be considered for organ donation. There's the heart beating cadaver. You're maintaining that perfusion, right? And then the non-heart beating are those that don't need perfusion. So if you're taking like the patient's heart to be for transplant, then you're going to be taking a heart beating. You're going to be using the heart beating cadaver, a patient who's dead but his heart's still beating. The non-heart beating, that's if you're taking like, liver, kidneys, um, just all kinds of other organs, whatever else you might be donating, lungs, that kind of thing. Um, these are for those patients that don't need perfusion. So this patient did die, and they kind of kept him alive um, by the machine because they're going to be an organ donor. So they keep him alive using the machine, and then once they do what's called cross clamping on the aorta, they actually clamp the aorta. That's when anesthesia stops, uh, maintaining the patient, because now they start uh, clamping off and all the vessels and everything like that, and then uh, taking the organs. But now you can run into an ethical issue if there was no clear picture on what the patient wanted before they died, right? And you never had that conversation. Hey, do you want to donate your organs or no? And then now you have a wife maybe who's saying no, but a daughter who's saying yes. And now there's and that's where we run into. So, um, sure, I know that. Good. And then for us, the staff, we may have prior experiences with death. Uh, you know, there's support available in the facility, like at Advent Health. You can go down to the chaplain, down to the chapels and stuff like that. But a lot of it's going to be based on your own kind of beliefs and values, what you think about death, how you view it, things like that. And what I found has helped is knowing, the process, how it goes about that. This definitely helped me with my dad last year when my dad died of brain cancer. He started with lung cancer and it spread to his brain. But knowing the medical side of it and how all of that process went and everything helped me deal with it a lot better than the sudden death of my mom. But uh, you know, it is just a part of life. It is, it's going to affect each one of us someday. So I mean, um, but what's really important is your own personal emotional well being in dealing, with death, and being able to find that support, get those people around you that kind of help lift you back up and remind you, why you're here and who you're here for. Those other people that are still here, things like that, and how you can always carry those that you've lost, with you, and do the things uh, that that they'd be proud of. So, um, but on that note, there's our infamous slide, the question slide. Um, I will be seeing you guys tomorrow. So enjoy the rest of your evening, and thank you.